One of the issues that has come up from CMS and my good friends at the Joint Commission is a lot of rules that are constantly changing, and the government's going back and they implement them and then they pull them back. Mind your way, sir. And one of that has to do with supervision. The requirements for supervision by physicians or other qualified practitioners, when the phrase is used in the regulations, has to do with both the medical staff bylaws and the state laws. So your medical staff bylaws has to define who is a qualified practitioner besides a physician. It can be a nurse practitioner, it can be a PA, and again, some of that also depends upon state law, what the state law allows them to do. But back in 2009, every year the CMS, they put out the outpatient prospective payment system. They also put out an inpatient one. But back in 2009, they said that hospitals had to ensure that the supervising physician's presence in the outpatient department, they were immediately available for direct supervision of outpatient therapeutic and many diagnostic services. Meaning that in 2009, when they put this out, it caused a shockwave through hospitals and their outpatient departments saying, well, where's our physician located and what's direct supervision? There's three types of supervision. There's general, there's direct, and there's personal. The general is basically that the person is under the care of a physician who is written in order, or perhaps in some states, depending, again, nurse practitioner. The personal is basically there face to face, but it's the direct that has caused problems. So after much complaint in the 2010, CMS issued a more flexible supervision by certain non-physician practitioners in interpreting direct supervision in the hospital or campus to mean the supervising physician or nurse practitioner, whoever, is on the same campus. So now they take it away from actually being in the same building or the same room to the same campus. What's crucial about same campuses, we've had the issue we dealt with, is that CMS defines your campus as the main buildings. They have an S on the word buildings, and we've argued that point, but buildings. So take your main building and go 250 yards from it. And and you can count your parking garage as part of your main building, but anything more than 250 yards outside of your main buildings is now off campus. And perhaps in places like DC, it's people build up, but in places like Tupelo, we don't build up, we build out because land's cheap. And so we built out, and we've had them say, no, that building a half a mile down that's been there for 30 years that everyone in the city, in the county, or in the region knows is just part of your hospital, we don't think it's part of your hospital. That's what the government says. So you have to be careful when you're looking at it. They're talking about on campus, the same campus, meaning your main campus. If you're off campus, then different rules may apply. And that was a problem for off-campus departments, which required the physician or the nurse practitioner, I'm just going to use that as a substitute, be present in the off-campus location. So, for instance, for our organization, we have a building that is probably about 600 yards from our main building. And that 600 yards from our main building is now off campus. And we go ahead and we have some therapeutic outpatient procedures done there. And because of that, we had to assure that at all times that we were doing that we had someone available. And some of the therapeutic services were infusion, oncology infusion, which are therapeutic, not the diagnostic. Most diagnostic ones are general supervision. You don't need anyone there. But for the therapeutic, we had to retain off hours, because we always tend to have physicians there during normal, normal hours for lawyers and stuff for like 8 or 9 to like 5 or 6. But physicians, 6 in the morning? They get up at all those 6 o'clock meetings in the morning. But whenever they leave, it's 4 o'clock, and those buildings kind of shut down, but you still had those therapeutic services being done. We had to retain nurse practitioners to be in the building. Or sometimes we get our second-year residents and say, hey, you'd like to make a a quick $75, $50, whatever we could pay them, and have them just sit there and they would just do their other work, but they would be available. It's an expense for the organization. It's difficult for some organizations who don't have the availability of residents or nurse practitioners. It also became difficult for critical access hospitals. That's where it starts getting a little more difficult, or if it's off the main campus, when you start getting further away from your main buildings. And the government, I sometimes get down to the nitty-gritty of this, and they had the word main buildings, and we argued with them. We had more than one main building. We had buildings, as the regulations say, with an S. Very technical reading. Government didn't see it that way, so we ended up with this problem. But it goes further. We're only in 2010 to show you this problem that you as physicians who have any role in this have to be aware of if you get into the administration, if you're medical directors. It was a problem for rural hospitals because they don't have necessarily access to it, and critical access hospitals, and potentially when you're off campus, if you don't have access to residents or nurse practitioners or the like, it's expensive to have a physician basically sit around in a room and just kind of sit there. You all may love it if somebody's paying you to do it, but it's expensive for the organization. So 2011. They addressed concern in part, and they eliminated the requirement that the supervising physician must be on the same campus or in the off-campus provider-based department of the hospital. Okay? Hold on with me here for a second. And they identified, however, a limited set of non-surgical extended duration therapeutic services for which direct supervision is required only for the initiation of the service. So that gets into and there's a list. If somebody wants it, I had it. I didn't put it on the slides. It's quite long, but I'll be happy to find it. But it changes. It's constantly changing. And I'll explain that in a second. But many oncology type of therapeutic services, that initiation of the infusion is considered one of those where you must have someone basically in that building available, readily available if something occurs. But once that infusion starts, then they no longer have to be readily available in that building. It can be the general supervision for the remainder. But again, stay tuned. CMS announced that they intend to establish an independent review process for evaluating the appropriate level of physician supervision for specific therapeutic services in calendar year 2012 OPPS. So there will be a list, it will probably not become a general standard, but a standard specific as to the types of therapeutic services being provided. This is different than diagnostic. You send someone for just an MRI, that's diagnostic. You don't need that. That's general supervision is on, and it's incident 2, but it's general supervision. Is it clear as mud now? But the point is, these supervision requirements for outpatient, it's going to constantly change. I can see when we get to 2012, 2013, 2014, you have continuing standards as it relates to supervision requirements for outpatient therapeutic. And when I'm talking, it's not diagnostic, it's therapeutic services they're looking at. They look at it from a quality of care. A prime example will be, we have a matter that's a professional liability claim. And as I told our outside counsel who handles professional liability claim, be careful. There's a red herring here if the plaintiff's counsels ever pick up on it. And that red herring is that there was a patient who had infusion, completed the infusion, did fine. And after they had the infusion, they went through their whatever checklist is supposed to go. They get up, they took a few steps, they fell on their head, subdural hematoma, got transported by ambulance, and they died. We didn't have, or we can't locate a qualified practitioner who was in the building at that time. So the one thing I did tell them to do is don't bill for the service, because that could theoretically be fraud, not having the person supervising. But those type of things, that's the reason CMS will tell you they want these supervision standards, so there's a physician immediately available to respond. If you dig into it, though, you find there's a little bit of a fallacy there, because if it had been a resident who had qualified, you know what they would have done? They would have called 911, and they would have got our ambulance to come across the street to 600 yards and pick up that patient. Yes, sir.
In terms of diagnostic incident to service, that's still direct, isn't it?
Diagnostic, when you have an MRI, and there's a whole different, that's listed in a whole nother study. But incident to services, where you have a diagnostic, you have to have someone generally available in the building. But they don't have to have that level of supervision where they're immediately available. To that gentleman's point in the back, you have an MRI, well, you probably have an emergency room physician in a small hospital available somewhere, or a CT scan, or an X-ray, or the radiology department. There's a physician somewhere in that building, and that will satisfy that requirement.
Does that physician have to have any interview with the billing or the supervision?
No. You just have someone available who can be contacted and is readily available in the event something happens. So these issues on outpatient, they get down to, again, I'm only going, I think, at a treetop level, but it gets really, really detailed and can cause great problems for physicians and hospitals and billing if you don't follow these rules. Something else that I looked at is a re-enrollment process. Some of you may be familiar with this, or you've heard about it, or your offices have done it, but the government is requiring physicians to re-enroll, and it relates primarily to home health, durable medical equipment, prosthetics, orthotics, and supplies. And the reason is that they want to go ahead and revalidate that the people, or the physicians ordering those services are truly enrolled in Medicare, and they want to try to establish some type of chain, whether you're employed by a healthcare system or you're employed by a physician group. They want to look at, and they're trying to tie up all these relationships. In reading through the Federal Registry on this, I drag it into the outpatient department because I can see that the government will start using this information from this enrollment process to go ahead and tie in the physician to a hospital for outpatient services. So the re-enrollment, this is part of the Affordable Care Act, and it was designed to prevent fraud in Medicare by requiring that only eligible and identifiable providers and suppliers can order and refer covered services to Medicare beneficiaries. So this use is going to expand beyond those few areas for durable medical equipment type thing. And they use the PAYCO system. That's what you may have heard, the PAYCO system. They've used the PAYCO system as the electronic system to enroll physicians. But another thing about the PAYCO system is that unless you enroll in the PAYCO system, you won't get your additional, I'm not sure if it's 2%, but your additional monies for EMRs. In order to get your additional monies, if you have for your physician practice from EMR, you have to be enrolled in the PAYCO system. Between now and this is a great working of CMS, because between now and March 23rd, 2015. However, the end date was somewhere in 2011, and because of protests by the AMA, protests of the AHA and other groups, they extended it. Now it's between now and March 23rd, 2015, notices of being sent to physicians of revalidation. Most of the physicians in our health system who are employed, we employ over 150, 160 physicians. They don't really, other than maybe asking them to sign the form, they're really not involved in it. It's our staff who handles it. However, if you're in private practice, please make sure you're aware of it. If you work for an organization and somebody else is taking care of it, make sure they're on top of it and taking care of it. Because if you're not enrolled, again, you won't get your money for EMRs, and it may affect your ability to order durable medical equipment for patients who actually need it, because it will be kicked out and rejected. And it may affect your ability in the future to order outpatient treatment at a hospital. I think I already said that. Downstream providers and suppliers are at risk of non-payment. So if you order it and you're not enrolled in the PAYCOs, that means that the DME company may not get paid, or the hospital may not get paid. Okay. Credentialing. Why do I put credentialing up here for outpatient departments? I know in our facility, we've looked at at time to time, particularly our smaller outlying hospitals, the issue of having telemedicine as a useful component for outpatient departments. We looked at telemedicine for psychiatry. We're not doing it yet. We use telemedicine at our main facility for our NICU unit. We are tied into the Bonner Sterling Hospital in Memphis, and they provide certain for neonatology in the neonatology unit for cardiology, as well as for some neurology, but mostly cardiology. So we use that, and we also looked at, we had a presentation by a group for neurology that they would basically have, it looked like almost something out of Lost in Space, this big thing that they would roll from rooms where you would have a neurologist when you had patients in an outpatient department or your ED, which is an outpatient department, who could go ahead and that neurologist would have that encounter because you have so many people coming in to outpatient areas with presentations that may be strokes. And a lot of hospitals don't have the ability to have neurologists on call 24/7. I suppose like a lot of areas, there's a shortage of it, and a lot of neurologists find that they can have a better lifestyle and make just as much money at an office-based practice as opposed to having to come in and take calls. So there are groups setting up for that. Well, CMS, along with the Joint Commission, has gone ahead and looked at some of these credentialing issues. One of the credentialing issues that some surveyors from CMS and Joint Commission caused a little problem with was stating that for outpatient services related to radiology, physical therapy, speech pathology, respiratory services, that only physicians who are on the staffs of hospitals can write those. And that's sent a shockwave through, at least through areas of compliance. I'm not sure if any of you heard about that, but it caused problems because we have probably 20% at our main hospital of all those outpatient services are written by physicians who aren't on our staff. They're just in their private offices. Docs who want to basically, primary care docs for the most part, who want to go ahead, take care of patients, refer what they have to the hospital for outpatient, refer elsewhere, but they're not on our staff. They don't want to deal with our issues of our staff. They just want to practice medicine. You have this condition of participation. Conditions of participation are everything that hospitals have to follow in order to be in the Medicare and Medicaid program. They're sometimes important and sometimes nothing more than draconian, follow the rules, dot your I's and cross your T's. But basically, under this condition of participation, radiology services must be provided on the order of practitioners with clinical privileges or consistent with state law, or other practitioners authorized by the medical staff in the governing body to order the services. That's what the condition of participation says. An interpretive guideline. So you have the law. You have the law is passed, and then once the law is passed, the departments go ahead and issue the regulations, okay? And then the regulations, you get the people in that department, the lifers, so to speak, in many of these government agencies, who write the interpretive guidelines. So you start getting sometimes far afield from what the actual law that was passed. And the interpretive guidelines went even further. And the interpretive guidelines basically, they were indicating that these folks who are writing these orders for certain outpatient treatments had to be on the medical staff or had to be approved by the medical staff, which caused some problems because, again, there are a lot of practitioners who are not. So with this, there are other conditions of participation related to nuclear medicine and respiratory care raise similar questions. So CMS was starting to get a lot of heat about this issue. So they were going to address this during a February 24th open door forum, which I actually listened to, and then they referred to a February 17th, 2012 memo from CMS to the state survey agency directors. And again, this is because of concerns by the AHA, the AMA, and other groups about the liberal expansion of the interpretive guidelines. So now what the memo says, by a practitioner who is responsible for the care of the patient, is licensed in the jurisdiction where they see the patient, and is acting within the course and scope of state law. So now CMS is kind of backed off. However, it's gone ahead and it still is starting to put a burden, more of a burden on hospitals and how they're dealing with physicians who are not on their medical staff and what obligations those hospitals have to have some oversight. Now, I will tell you that the oversight that our medical staff has expressed about about practitioners who are not on our medical staff actually have to do more with nurse practitioners. They've expressed concerns about some of the frequency of the test ordered and the need for the test. But when you read through all this, I think in the future that if you are not on the staff of a hospital, but you refer to that hospital for outpatient procedures, between the Joint Commission and CMS, as well as the enforcement agencies of the OIG and the Department of Justice, that at a minimum, hospitals will be sending out, maybe it's a one-page sheet, and they'll be asking for your name, your education, your license number, so that your insurance, to make sure you have insurance, some level of insurance, and to verify if you've been excluded. Basically, an attestation, perhaps, that you've not been excluded from Medicare, and a list of outpatient services that you request to order. So I think we're going to eventually move, and we may have medical staff bylaws may actually have a category. It won't have to go through a full credentialing process, but there'll be a category. Outpatient practitioners, whatever you medical staff want to call it. Yes, sir.
Actually twofold, because I'm in a small hospital and I sit on both the bylaws committee, and I've been the chairman of credentials for about 8 years. So I was sitting there going, how are we doing with this? And we actually credential all of our non-admitting doctors. They are members of our medical staff. This wording is probably not going to hold up long under these rules, but without privileges. And they are fully credentialed. They could be inpatient managers if they wanted to be, because we run them through the same process. And once again, as you mentioned in the last part of your slide, we probably need to change our bylaws to specify that they can continue to order outpatient privileges and things, but they're fully vetted, you know, as far as licensure and everything.
And you can go that you can go a full credential. You don't have to. I'm suggesting that we have a lot of practitioners for our main hospital, 600 beds, where they're not. There is nothing, and other than us running an exclusion check on them ourselves, because if they're excluded, we can't charge Medicare, Medicaid for that. But we may need to do a little bit more, and part of it, you hit the right key, is changing your medical staff bylaws to reflect what is needed for these practitioners who don't set foot in your facility, who only go ahead and order tests. If you do what you said you do, and that's perfectly fine, the downside of that I could see from a Joint Commission standpoint is Joint Commission coming in and say, okay, I always get these initials wrong, but have you done any evaluation of their quality of practice, what is OPP or E?
And I sent him a request for some quality data from his practice. And it may not hold up in the grand scheme of life.
Well, at least you're doing something.
But we have, this is an area of credentialing that has not been addressed.
You're correct.
And we don't really know how to handle it with absolute certainty, but they can't say we didn't do anything. And I made him generate me a list of what he's seeing, how many he's seeing, what their levels of acuity are. And that's all I can do.
Yeah, and what I suggest, again, what I suggested, whether it's credentialing in other areas, is that you have standards that are out there, and then hospitals said, whether it's medical staff bylaws or policies and procedures, I always caution to make sure that you don't set your bylaws or your policies and procedures at a much higher level than what is required, because when you do, you're not held accountable for what is minimally required. You're held accountable for what your policy and procedure says. So if your policy and procedure for outpatient is higher than what's required by CMS or Joint Commission, you're going to be held to that higher standard. So you have to, and what I do suggest though is that a lot of hospitals, including our main hospital, we don't do anything on practitioners. All they send is, and we're going to probably have to do something in the future. It'll be, I see two, so I won't miss it. Sure.
The same issue, Robert, and I sit on the credentials in our hospital that we're both on. And what we did is we created a separate category of privilege for those, and we added it to our bylaws and actual policy and procedures so that we don't have any data on their inpatient staff, and we did the same thing, and we kind of wrote it out that, yes, we can evaluate what they do in their offices, if they're at, ASCs and what they're doing for procedures, or anything that we could get, is what we wrote into the last week's credits. I figure we call it, we called it something, but a separate procedure for a separate class of those people being on staff. And they don't come to the hospital, they can order, but they can send.
We also have one provider who wants to maintain his privileges, but he hadn't put a patient in the hospital in
Right,
3
which
years.
is
And
what
then
we
you have the issue of quality review. How do you evaluate the quality and their ability to be on your staff to actually admit patients when they haven't admitted patients? And so, that's a trick, and you're going through, and these surveyors, I have to tell you, these surveyors from Joint Commission, some of them are very good, and some of them, I'm not sure where they came from, because they were reading rules that don't exist.
Have the separate, it's the same thing at our hospital. Everybody's credentialed the same, even though, like, we don't admit at all to the hospital anymore because they have hospitalists. So
Right.
all we do is use outpatient services. So, but everybody's credentialed the same. So if you create this different category, then do they not have to have the quality assurance back up in, like, for Joint Commission?
If depending how you write your policies and procedures, and depending on what they do, you can have various levels. I can see that used to have active, basically, and inactive, or active and consulting. That was about it. Now I can see the day where you'll have about 10 categories of medical staff, depending on what they do. You can have active, okay. Then you have people who will, all they'll do, they'll never set foot in a hospital. That would be one category. Then you have, for instance, I'll get to in a minute, the telemedicine. You'll have issues of telemedicine. Then you'll have those physicians who are itinerant, for lack of a better term, or those physicians. I've talked to my son, is at Ole Miss, and he decided he wants to go to med school. I think that's part of it, so it can be the 5-year plan at Ole Miss instead of really, but instead of just taking, so he can triple major in order to go to med school. But he talking about certain things, ED physicians. We have ED physicians in our facility who work whatever they say, 7 on or 7 off, but they don't live in our town, and they move elsewhere. We have we experimented with hospitalists through a contracting agency who did the same thing, and we're looking at traumatologists. And so there's a category that if they're truly not invested in your community, particularly when you get to rural areas where, and do they have those full rights to vote on the medical staff issues that could affect things that, they're not there all the time. So you may have a different category of active staff. So as it relates to outpatient, inpatient, and all the different areas, you have to go ahead and start looking at your medical staff bylaws, and you have to go ahead and start really fine-tuning them to fit the categories that you want, and make sure you're meeting all the requirements of Joint Commission, of CMS, to do quality reviews, but not putting such a burden on your medical staff office and your physicians who sit on the committee. Yes?
Order laboratory studies and radiology studies that are done at hospitals 100 miles from where I am.
Mm-hmm.
And I'm not on staff.
I
don't have any credentials there.
And I think the issue for them, if they're going to go ahead, you may set thresholds. I mean, we send stuff, our hospitals send like the mail. Some lab work the mail. I'm sure mail doesn't want to get in the business of doing it, but you may set as a medical staff, you have a doctor who's sending every day, referring outpatient every day. They may say, look, we got to have some verification of what's going on here. But that hospital, if they're not getting the information from you, they have to go ahead and do the work to make sure, at the very least, that this is a problem, that you're not excluded. And it's amazing that you can be excluded from the Medicare program for something you never thought of. And if you're excluded, every single charge that hospital bills for an excluded practitioner's order is a false claim. And let me explain real quick how you can get excluded without even thinking about it. Remember, I'm a privacy officer. We had a physician. There is Little Rock. Anybody here from Little Rock? Okay. Remember, you had the newscaster in Little Rock who was killed, right? Okay. That hospital, I don't remember the name, it's irrelevant, but they had an electronic medical record system. And they probably do it, we do it at our hospital, a lot of other ones. They ran an audit. when that newscaster came to the hospital, and they found out that there were 3 nurses and a physician who had no business being in that record, looking at that record. So the nurses were employees and they were terminated. The doctor wasn't an employee, but he lost his privileges at that hospital. Okay? You think that's the end of the story? Well, what happens next is the U.S. Attorney's Office goes ahead and decides to prosecute, people may say persecute, that physician and the nurses. Well, they pled guilty to a misdemeanor. They pled guilty to a misdemeanor of violating privacy. They paid a fine, did not do any jail time, got probation. Usually, to get excluded, you have to be convicted of a felony. However, because the misdemeanor was related to a healthcare issue, they are now excluded from Medicare. I don't know. I can't answer that. I've not represented someone who's been excluded. I don't think it's forever. I think there's a period. In the back of my mind, I always say 10 years, but I could be completely wrong in that. But you are excluded from Medicare solely because you looked at privacy, you violated privacy. And when you violate, if you get excluded, then that hospital, we have a physician, excellent physician in our town of Tupelo, who ended up because he was the medical director of a hospice agency, not ours, and he was accused by a zealous Attorney General's office of overprescribing or ordering medications or approving medications for hospice patients. And it got so involved that 2 of the investigators for the AG's office were terminated for being too zealous. But he got involved in this, and this physician, good physician, his son and my son went to high school together. I know him very well. One night he got so angry about people posting things on blog. Apparently he posted what was conceived to be a threatening blog against some of the family members who sued him out of this AG's thing. So he ended up pleading guilty to a misdemeanor. And as a result of pleading guilty, he then got a notice from CMS saying you're excluded from the Medicare program. And so it's something very simple can end up in exclusion.
Will the commercials exclude you as well?
They could. Again, I've never represented any physician personally on that because when I was in private practice, I've been with our health system for 16 years. Before that, I was with a firm in New Orleans called Jones Walker for 12 years. And back then, the government really wasn't excluding folks that often. Today, they are. But it could. It's like Joint Commission certification. To be quite frank, we talked about it. What does it really do for us? It makes it a checklist when we get the commercial payers to go through and because we can get certified by the state and save a bunch of money. But that's a very good point. You could end up with some private payers. And the physician in our town who's excluded, he's basically, I kind of overheard when I was sitting in the hallway, the speaker before me talking about concierge type practice. I think he's open a concierge type practice. So, but we had to go ahead and he got a little angry with the administration of our hospital after he was excluded, and he was sending over for a test, and we told patients, and we told them we couldn't do it because of the exclusion. So you have to be real careful about that. Yes, sir.
That has opted out of Medicare, but is still working at your hospital. Is that possible?
We've not had that situation, but opting out is not the same as being excluded. But the issue of opting out, if you're on your medical staff, you need to look at your medical staff bylaws because they still may be required to treat Medicare patients. And then if they're opted out of Medicare, I'm not sure how they're going to get paid for their services. Our medical staff bylaws are written in such a way that if you're on the call panel, you don't have a choice in any way, shape, or form who comes in for unreferred call. So the issue is going to be the unreferred call. Off the top of my head, the unreferred call, how do they handle that when they may not be able to bill Medicare for those services?
For example, if you had a physician in the community that wasn't credentialed at your hospital and say overutilizing MRIs, just ordering tons of them unnecessarily, it's found to be the case, could the hospital also be responsible?
Absolutely. The Office of Inspector General would come back in and say, hospital, you have a responsibility to know what's going on in your facility. Have you heard of kyphoplasty? I personally, I represented our hospital. We settled the kyphoplasty. I dealt with the Office of the Inspector General. Same type of concept. Those physicians were on our staff, interventional radiologists who did the kyphoplasty case. And the argument, of course, is that those physicians, they're skilled, they're trained, we defer to their expertise. And he said, sorry, you hospital have the obligation just to go ahead and you have oversight responsibility to see what is going on at your facility for ordering of procedures, whether the procedures are medically necessary, whether they're performed in the right location, and whether you're billing for the right service. And you can do that through many different ways. One of them is, I'm drawing a blank. You do a random audit.
We look at, 10 of our MRIs each month and see if they're appropriate.
That is one way to do it, is random sampling. If you have a compliance department or audit department or somewhere, they should be taking on that responsibility. If they have a problem, and it's whether they're questioning whether they're medically necessary, then that probably should kick up to the medical director or someone along there to weigh in on that. I agree, but again, I say this tongue in cheek, but I've dealt with the Office of Inspector General and the U.S. Attorney's Office in the past 3 to 4 years, more often than I spent in the prior 10 to 12 years that I've been at the facility. Not that we've done anything wrong, but they're questioning everything that we're doing. So, did somebody else have a question? I'm kind of going off field.
About the kyphoplasty.
Yes, sir.
When they looked at the kyphoplasty with you, did they also look at minimally invasive discs, or did they just list it right on kyphoplasty?
This is a kyphoplasty.
That's the next obvious target.
Yes, and I'm also dealing with, I also dealt with different U.S. Attorney and different Office of Inspector General on implant and ICDs. That's an area they're looking at. The government is basically, I keep telling you to get all these titles. I'm also a coordinator of our RAC program. Now, I don't do it day to day. I have, there's people, but I've kind of, and some of the things that you have denials for that are moving from inpatient to outpatient. I told my wife this one and she was shocked. And one I told her about had to do with, I'm sorry if I'm turning my back, had to do with mastectomies. I said, do you know right now, unless there's something unusual, that Medicare eligible females who have mastectomies have to have them in an outpatient setting and they go home the same day? And my wife was absolutely shocked by that, saying, you're kidding me. I said, nope, that's the government. The government says they don't need to, that it's not medically necessary to be done with an overnight stay. And if 23 observation is acceptable, you can go ahead. But again, you have to be careful. There's information that's coming out on observation, as I mentioned earlier. The government is looking at to making sure that there's not a routineness of every patient who has outpatient surgery then being moved to observation, because the cost of the observation is actually almost more so on the beneficiary than it is on the Medicare program. And so they don't want the beneficiaries to go ahead and get hit with those higher, I'm not sure if they're co-pays or deductibles or co-insurance, whatever they are. But they're looking at that. I'm sorry to digress. Okay, so we go ahead. I mentioned telemedicine. Now, so credentialing for telemedicine. In May 5th, 2011, they issued CMS issued a final rule under the conditions of participation. And you can do, perhaps what the gentleman in the back has said, you can credential all your telemedicine providers in a full-blown credentialing. Or, under these new rules, the hospital can enter into a written agreement with the distant site provider. So if another hospital, like Le Bonheur, we're using Le Bonheur for pediatric cardiologists, we can enter into an agreement with Le Bonheur. And that agreement with Le Bonheur, since Le Bonheur is approved by CMS, allows us to go ahead and utilize those pediatric cardiologists without going ahead and having to credential all those pediatric cardiologists. Now, we may have some basic information, again, like I said on the outpatient name, they have insurance, they're not on an exclusion list, but basically taking it down to almost a sheet of information. And we can rely upon, if we want to do a little bit more, we can rely upon that other hospital that is CMS approved for their primary source verification. So we don't have to send out all the information. If we wanted to take it up another step, we could ask them to send all that information. We don't have to verify it. We can go ahead and rely upon it. Now, you have to be mindful of several things. You have to be mindful of state laws, because every state has a different law as it relates to telemedicine. Most of the Labana providers, it's not an issue because most of them are licensed in both Mississippi and Tennessee, so we don't have an issue with that. But if they're not, if you had a pediatric cardiologist in Tennessee and they're not licensed in Mississippi, well, under Mississippi telemedicine law, I can't speak to other states per se, but we would have to have a Mississippi licensed physician actually sign off on that final report and be completely responsible for what they do with it. So that pediatric cardiologist would have to tell the neonatologist, for instance, what his interpretation of the report would be, and then that neonatologist can parrot it, but they're responsible for that report rather than the pediatric cardiologist who's not licensed in the state. And your medical staff bylaws must go ahead and address how it works. So you can go ahead and have the agreement with the distant facility, and the agreement with the distant facility will allow you to basically accept everything other than one page, or you can have an agreement with the facility where you can accept their primary source verification and credential them yourselves, or you can still credential them all in the way you do it now. So you have 3 ways to do it.
That's very interesting. In my facility, we do the full-out credentialing for our telemedicine docs. And just last week, we had one who had, I think, 8 state licenses and worked in so many hospitals that by the time the vetting process was over, his application was over 800 pages.
You don't have to do that anymore.
We figured there's got to be a better way.
Well, I just gave you 3 topics. Somebody in your facility can go ahead and go through it. You can go ahead and enter one of, if you're at a distant facility, or, like I used the generic term Nighthawks. Nighthawks, for instance, they actually are I know for radiology, they're CMS approved, so you can rely upon them. You can enter an agreement with them. It doesn't necessarily have to be a physician. It has to be someone that's approved by CMS or JACO in order to go ahead and do the credential. So you can perhaps rely upon them. Any questions?
If you go back, when you define a campus, a hospital campus, what do you mean by campus?
Sure, it's a good question. I think that it was at provider-based outpatient departments.
Right.
Okay, I wish I had a little diagram. May not work, but let me go ahead and try this. Okay, I'm not very artistic, but we've dealt with this issue. In fact, I'm still dealing with it at CMS. Okay, this is say you have a plot of land and you have your main building here and you got your parking garage here. Okay, this is actually kind of where our main campus is. We got a little tower that comes here we're adding on to. That's your main building. Now, let's say you're about 100 yards and we got another building right here. That's the main campus, okay? Now, let's say within 250 yards, you have another building, so that's 150 yards. You can argue that this is all part of your contiguous campus. However, let's say you have a building that's 100 yards right here, and your next building you have is over here, and that's a half a mile. That is not part of your main campus, because when you measure it from, say, your parking garage, your farthest spot, if it's more than 250 yards, no longer your main campus. It's off campus. Now, one of the things about off-campus, you're off-campus, and it has to, if it's greater than 250 yards from your main buildings, we keep our main buildings to the government, and it can't be greater than 35 miles. If it's greater than 35 miles, it can't come under that same license. Those off-campus departments, they have to go ahead and post certain notices that you don't have to post in your main facility, and they have to provide the patient with an estimate of their financial liability, which is the difficult component, prior to the provision of the services. So that's where it gets a little tricky. You have to basically tell the patient, hey, you're going to have, let's say you have half a mile away, you got an outpatient diagnostic center, and you send the patients there. You're going to have to project for them, it's going to cost you this much, we believe, for your MRI. Now, those outpatient departments are under the same license, because if you get more than 35 miles or you don't qualify, meet all the rules, then you have to get a separate Medicare provider number. And you have to go through separate state regulations as the license of another hospital. So you want to keep it the same. Those outpatient departments have to be under the same governing body. They have to be financially integrated with the main campus. They have to be it has to be a cost center on your cost report. It has to go ahead and basically the medical director for your organization, it has control over not only that main campus, but those outpatient areas that are greater than 250 yards. So it all has to be financially integrated and basically follow the same policies and procedures to be subject to the same governing board and medical staff bylaws.